This is the case of the incredible shrinking valve, an unusual cause of mitral stenosis. This was a 28-year-old female who was a known case of rheumatic heart disease, complained of increasing dyspnea on exertion. She had a transthoracic echo in 2018 December. This was the echo. So we can see that the valve is thickened, there is some restriction of mobility, and there is a significant mitral regurgitation with an LV dilatation. LV function is good. As we can see, contractility is quite good, and the mitral valve opening is reasonably good, though there is some commissural fusion. The stenosis is not significant. The mean gradient across the mitral valve is 4 millimeters of mercury. So we diagnosed a moderate to severe mitral regurgitation with no significant mitral stenosis. So this case was referred to us by a cardiothoracic surgeon who was keen to repair this valve. So he did a repair in the first week of 2019. He did an annuloplasty plus repair of the PML with the pericardium. The patient was extubated a few hours after the surgery and was stable. However, on the second post-operative day, the first post-operative day, surgery was repeated. Now, as you can imagine, the acoustic windows were not very good, but we can see the annuloplasty ring in situ. But what we also observe there is restriction of mobility of the mitral valve, and we can see turbulent flow across the valve now. The short axis view, again, not very good, but the mobility is certainly, the opening of the valve is certainly much less than it was earlier. We can see the highly turbulent flow across the valve. And the mean gradient across the mitral valve is now 14.9. This is significantly stenosed. In the evening, the patient's condition deteriorated. She was reintubated. The blood counts increased markedly. The X-ray chest showed lung field haziness. On the next day, the TTE was repeated again. Again, similar findings, restriction of mobility of the valve. There is certainly restriction of mobility in both the views that we see. And we can see that the very turbulent flow across the valve, and the mean gradient is now 17.4 millimeters of mercury. So what happened here? Well, I looked through the literature and we found that acute mitral stenosis following mitral valve repair is a rare but severe complication. In this particular study, the medical records of 552 consecutive patients undergoing mitral valve repair at a single institution were reviewed. And they analyzed the transesophageal echo of these patients immediately after the patient came off bypass, and they recorded the transmitral pressure gradients and the pressure half time. So all the patients undergoing mitral valve repair at Brigham and Women's Hospital in these 2 years were analyzed. Out of these, 27 patients were rheumatic heart disease patients who had a mitral valve repair. The others were of varying different causes. And the decision to return to cardiopulmonary bypass and redo the MVR was individualized based on the degree of hemodynamic instability, comorbidities, and so on. 9 patients, that is 1.6% of the total patient population, with intraoperative evidence of TE of restricted mitral valve leaflet motion, they underwent reoperation for mitral stenosis prior to hospital discharge. 4 of these 9 patients underwent surgical revision, and all patients were receiving inotropic and pressor support. All patients survived to be discharged from the hospital. And this authors concluded that the peak and the mean transmitral pressure gradients proved most reliable for detecting post-operative acute severe MS, and they were easy to acquire and reproducible. The pressure half time was not useful, PISA was not validated, and 3D TE measurements of mitral valve in this area, in this situation, had not been studied. So that was my case, and the conclusion that we came to was, of course, that it was a iatrogenic mitral stenosis. The surgeon had, in his enthusiasm to repair the valve, created a mitral stenosis, which caused the patient to go into pulmonary edema within a few hours after the surgery. The TLC rose, because presumably she developed an infection. The surgeon was worried about going in with such a high TLC, so nothing much was done, and the patient eventually succumbed on the third postoperative day. Now, lessons to be learned from this study. I feel maybe if I had been a little more emphatic in discussing the findings of the surgeon, though we did discuss the findings, if I had been more emphatic that the only way to save this patient would be to go in and redo the surgery, maybe this patient could have been saved. I don't know. Hindsight is always 2020. But this patient we lost, and it's a very memorable case for me, though not in a very good way. That's all I have to say. Thank you so much.